The study we conducted is called the ACCORDION study, and it's the continuation of follow-up of participants who were in the ACCORD trial. And ACCORD is Action to Control Cardiovascular Risk in Diabetes. So ACCORD was an intervention study that for the blood pressure part of it lasted 4.7 years. And so what we did is after the end of the study, we stopped intervening on those participants, but continued to follow them for the next up to 5 years. So we had an average of about 8.8 years. So we wanted to see whether any findings that we saw or didn't see during the active clinical trial, where we compared a lower blood pressure level of 120 millimeters of mercury systolic to 140 millimeters systolic. Those were the two randomized groups. We wanted to see if after we stopped that, there was what many people might call a legacy effect. Did something new appear in the next 5 years of just following those patients, or did what we see during the study disappear? ACCORDION was done in patients with diabetes. So they had diabetes mellitus and they had elevated blood pressures, and they could actually already be on therapy. So we had a range of blood pressures between 130 and 180 millimeters of mercury systolic, whether or not they were on medicines. And so the more medicines they were on, kind of the lower upper level, they could get in with their criteria. But so in addition to having diabetes, at least for a couple years, and the average was about 10 years actually, then they had to have some other risk factors or known cardiovascular disease to get in. They had to be above age 55 if it was just risk factors, or above age 40 if they already had known cardiovascular disease. During ACCORD itself, the active intervention trial, which we reported back in 2010, we saw only a 12% lower cardiovascular event rate in the intensive treated blood pressure group, and that was not statistically significant. We did happen to see about a 40% reduction in stroke, but that was a secondary outcome, and so we did not feel that it was definitive to say, well, we should now go treat people to 120 millimeters of mercury. So in continued follow-up, we were, as I said, trying to find out whether something new had appeared, which has occurred in some studies in diabetes, typically not so much in blood pressure studies. But we've seen, therefore, in the ACCORDION follow-up, which was an average of 8.8 years of following these participants who had been in ACCORD, we did not see any new differences that appeared. And the stroke difference that we saw during the trial became insignificant and was less than it was during the trial. And so that's not so surprising, but it is what we found. And so it suggests that if you stop the intervention, assuming that stroke difference was real, then you're not going to continue to get benefits. You have to maintain the lower blood pressure. We did find an interesting interaction, if you will, where we saw that the participants, so everybody in the blood pressure trial in ACCORD was also in the glycemia trial. So it was a factorial trial. And what we saw was an unusual interaction, such that patients that were in the standard glycemia group, which was about 7 to 8% hemoglobin A1C at baseline, as their goal A1C. What we saw in that group was a significant reduction in the cardiovascular event rate by about 21% in this long-term follow-up. We also saw that difference during the trial itself, where we saw a 26% reduction in cardiovascular events with the blood pressure intervention in the standard glycemia group. But the interaction was not significant, even though the amount of reduction itself was significant. To do the blood pressure intervention, we use the same kinds of medications in each group, the standard and the intensive group. We just used more medications, either higher doses or more numbers of medications in the intensive group. We had a wide variety of medications, so all of the major classes of antihypertensive drugs were able to be used. Most commonly drugs like ACE inhibitors, angiotensin receptor blockers, thiazide diuretics, or calcium channel blockers. Those are the most common that were used. So the take-home message is that we didn't see a long-term effect that was significant for intensive blood pressure control in these diabetic patients, but there were some suggestions based on subgroup analyses that there might be some benefit there. And so I think the important thing is to look forward to how guideline committees will view these data, especially in light of the SPRINT trial that's going to be presented and published at the American Heart Association tomorrow. And so SPRINT used the same blood pressure differences, 120 millimeters mercury versus 140, but showed a highly significant reduction in cardiovascular events and mortality, but in a non-diabetic population. So the question now is, should that be extrapolated to this other high-risk group of people with diabetes? And I think time will tell how guideline committees and the medical community will respond to that.